Good afternoon. I realize I'm the last person standing here, possibly between you and your cocktail later, so. Oh, okay, I'm the last speaker. All right, well, bear with me and I'll buy drinks later. So we've had such a good day of discussion and covered a lot of territory. I just want to take a step back. You know, our workshop here is about establishing effective patient navigation programs in oncology. So I thought it might be nice to try and incorporate several things that we've discussed, especially in this section here. And I thought I might try and do that sort of as a case study of some of the things that I experienced. I've been in my role for about 5 years now, and my program is definitely not the only model. As we've seen, lots of people are doing things in different ways because of where they are and the way things need to be done. But I thought maybe you could benefit from some of the things that I learned going through. Green button. Middle one? Ah, gotcha. Got it. So these are just some of the objectives I'd like to touch on during this talk. Let me just start by telling you a little bit about myself. I am an oncology nurse. I have always been an oncology nurse for almost 30 years now. Oncology has always been my passion, and I think like most of us, it touched me personally. My mother was diagnosed with breast cancer when I was 9, and she survived for 20 years until she ultimately passed away from breast cancer. But it left a big impact and a desire to help other families that are going through these difficult times. I work at the Levine Cancer Institute. It's part of the Carolinas healthcare system, which is a very large healthcare system in North and South Carolina. I specifically am in the Levine Cancer Institute, and that is also growing across the region. But I'm going to focus specifically on the 8 facilities we have within our COC network. Those are the facilities that I primarily work with, and the navigators there report to me. We are considered an academic, multi-site, community-based cancer center, which is a bit of a mouthful. We have, as I said, 8 facilities. We navigate approximately 12,000 new cancer patients annually. And now I have 28 awesome navigators across my COC network. When I started in this role, we were only at 1 facility, and I had about 7 navigators. And being that my background has always been in oncology, I had been on the inpatient side, I had been on the outpatient side, I had been in clinical trials, but I hadn't been in management. So, you know, I'm going into this new role over this new department, and oh, by the way, they told me we have a surveyor coming in 9 months. So that's sort of how I felt. It was overwhelming to me at the time, and I basically felt just like this. I was not sure where to begin, and Nina discussed the standard just a little bit ago, and that is really a key for anyone who's starting their navigation program. It really gives you the blueprint as to how to start your navigation program, essentially. I've highlighted some of these things, and she's already been through it, so I'm not going to read them all. But I hate to tell you, when I started in the role, I did not know what the COC even was, so that was 5 years ago. I got up to speed quickly. And where to begin after knowing what I know now, what I would say the best place to start, which I did not start at, but now I would recommend that everyone start with a community needs assessment. It really gives you a map. It takes a high-level look across your system so that you can see exactly what is there currently, what is in place, and where are the gaps, where do you need to work on. It brings all of your stakeholders, the buzzword of the day, together. Even though it falls under the navigation standard of 3.1, that doesn't mean that you're the only person who should be involved in working on this. So we brought in tumor registry, ACS, social work, just all sorts of different people to see what was currently available and where we did find gaps. And then that allows you to focus on the biggest area of need. So you're not just willy-nilly going around trying to do something, especially with limited resources, as we already talked about. And this is one of the best things that I did not realize at first. It provides you with leverage. You, by doing your community needs assessment, and as a group, deciding on those things that are most important, you can add that into your community needs assessment, and it gives you leverage with administration. Because once that's in there, there is definitely pressure on them to need to try to meet those recommendations, I guess, so to speak. So one of the things that we had come up with that we noticed in our area was that we lacked financial counselors. And the navigators did their best and the social workers did their best, but we didn't have anyone who was really working on getting the chemotherapy certified and all before patients were going on to treatment. It ended up costing the system quite a bit of money. So we were able to justify that, and it was in the needs assessment, and so we were able to get more financial counselors, which was a benefit for our patients. So this is another issue that we've sort of touched on a little bit today. When I came into the role, there was no standardized process whatsoever. Everybody was taking on a different role, and most of the tasks were being determined by the physicians or the clinical managers. Now we have so much more as far as, you know, our competencies that direct us and define the scope of what navigation should be, but those weren't available back at that time. There was also no standard documentation. People were not documenting at all where I was. They were either sending emails or I have Cerner where I am, and they would send Cerner messages. But it was really a very ineffective way of communicating with the physicians and the other multidisciplinary members of the team. Some people were using Excel spreadsheets, but some weren't, so there was no way of tracking what was going on with our patients. And we really didn't have any tools in place to be able to track the information. So when you have a lack of standardization, it causes confusion. And navigation, as we know, it cannot be one size fits all. That's just not the way it works. It's never going to be that way because of just the way cancers are diagnosed. And the way people come into the system, what the resources are available in each different facility. But we have so much more in place, and like Mandy was talking about, we need to work hard on building on the things that are already there. One of the things that I get asked a lot when I either have a new physician coming into my area or when I go out to one of the smaller facilities is the quality of care is not consistent across the board when we don't have standardized processes. And the navigation role itself is confusing. The physicians constantly will tell me when they come into our system, I'll ask them, have you had a navigator before? And they'll say, well, yes, but I don't know that my navigator does what your navigators do. So, and patients also aren't always clear on what it is that we're doing. And I think as a profession, it's really important that we continue trying to standardize in those areas where we can. Metrics were not being collected since there was no documentation done. And again, we need more information available for those evidence-based practice and research so that we're able to show the value of navigation and what our navigators are able to do for our patients. When we all combine and are focused on the same metrics, like AONN put out, you have strength in numbers, so we can all start demonstrating what it is and the effect we're having when we start working and following some of the same metrics. So what we did, or what we decided to do at the Levine Cancer Institute, is I focused on developing 2 informatics systems to try and help with both the documentation and the collecting of more data. And we wanted to support a standardized navigation process by doing that. We wanted to help our navigators manage large patient cohorts. My navigators right now navigate an average of 250 patients, which is a lot for anyone to keep track of. And of course, we want to capture metrics for managing the program itself, and it helps to improve communication. Now that we have more facilities, there's oftentimes we like to treat patients closer to home when we can, but as we talked about earlier, sometimes there's a surgery that can only be done at one of our locations, and then we try and return the patient out to the rural location. And when we didn't have documentation, it really hurt our communication. So this is the first tool that we developed within the EMR, and this is in Cerner, if it looks familiar to anyone. It's a power form that we developed. It allowed me to start tracking things from a management perspective. I was able to look at time spent. There were a lot of things that were a part of the metrics that AONN has come out with. We use a acuity grading system there so that when I look at 50 breast cancer patients, it's not the same as 50 head and neck patients, and that's important to take into consideration. There's lots of multimodality coordination that needs to go into some of those patients. It was able to tell me how many minutes they spent, what type of visit was, and this is all information I was able to take back to administration in order to justify additional FTEs that were needed. And then this is another tool. We recently have refined it somewhat. This is a Cerner tool. It's a care management new tool that they've got, and they actually did some special adaptation for us. So that looks like a whole bunch of gobbledygook up there, but what that is once a navigator enters her patient into this system and identifies it as one of her patients, it's able to automatically populate all of their patient appointments that are coming in. It's also able to designate whether or not it's an infusion appointment. If it's radiation, as you see, they can filter when they have surgery, because when you have that many patients to manage, you just don't know what you don't know. It's hard to keep up with all of them. The other thing that it does is it will, in real time, alert if there is a hospital admission or an ED admission, so that they're able to more proactively manage that and follow up with the patient when it indicates that they've been discharged. So because we started tracking information, we have been able to do some exciting research and outcomes so that we are able to demonstrate value. And we did a study looking at our patients that was presented at ASPO a couple years ago. And of course, we all know hospital readmissions are expensive and we don't want them. So because we started tracking in the way that we did, we were able to see who was a navigated patient and who was not a navigated patient. And we found some great results that the non-navigated patients were 52% more likely to have a 30-day all-cause readmission than a navigated patient. And here is just a little bit more detail on that. These were unplanned readmissions, so not surgical or scheduled. And something interesting that we found in what we looked at was that pancreatic really benefited a lot. We did not have navigators navigating all of our pancreatic patients at some of our outlying sites. They were colorectal navigators, so we did add pancreas as a site now based on this information since they benefited so much from it. And this is another really exciting study. Again, we looked at 8 poor prognosis cancers, poor prognosis determined by the American Cancer Society, and we wanted to be able to get some results fairly quickly. And so we were able to look at navigated versus non-navigated patients. This was a retrospective study, and I'm sorry, it doesn't have the number of patients. I believe it was about 2,000 that they started with. They used propensity score matching on multiple different factors to try and make sure we were looking at apples to apples, and we were able to show that there was a benefit of the patients that were navigated versus the patients that were not. We have had that data mature to 24-month data, and as you can see, it's about a 30-day difference there, but now the 2-year data is very exciting. We're trying to get an article published now, and it's more in months rather than days or weeks, I guess you would say. So we're very excited about that. Hopefully we'll get that published. Navigated patients, this is, I don't think, really news to anybody, but it did show that navigated patients were more likely to receive support services, nutrition, palliative care, social work, and something else that it was able to demonstrate was that patients were more likely to receive equal to or greater than 85% of relative dose intensity. So that was important too. And there were fewer missed visits, which probably was part of that as well. So, in conclusion, this is a debate we sort of started earlier, but standardization in navigation is difficult. But now that we do have the tools available out there through ONS and AONN and some of the other things that you're talking about for the non-nurse navigators, it's important that we are building on that, not trying to recreate the wheel, because it does cause confusion, I think, out in the community. So where we do have those tools available to us, it's really important that we continue to build on that and gather more metrics so that we're able to expand our volume of evidence-based practice. And then I do have just a few sites that could help with some of that. And those are the people who helped me, the Translational Research Department. It was a big help with our studies. So, thank you.